This is a 48-year-old man with a 2-year history of blurred vision in his left eye. He denied any trauma and visual acuity is reduced to light perception only. The triple challenges are loose zonules, fibrotic capsule, and a hypermature Morganian cataract. Plan A is capsular fixation and IOL in the back. Plan B is phaco of the nucleus and scleral IOL fixation. And Plan C is extending the incision and scleral IOL fixation. Injection of vision blue is followed by OVD. Capsular puncture and followed by immediate and sustained aspiration of white milky cortex. Eventually, a small brown nucleus became visible briefly. The fibrotic capsule is extremely resistant to tearing with a bent 27 gauge needle. Capsulorhexis forceps is tried, but fibrotic capsule is again resistant to tearing and compounded by lack of countertraction from weak zonules. Capsular hooks are used to assist in countertraction. Finally, capsulotomy is completed with scissors. The small brown nucleus is then floated into the anterior chamber with OVD. Since CCC is not intact, therefore decision is to proceed with Plan B, phaco IOL scaffold and Yamane fixation. A 3-piece IOL is then injected posterior to the nucleus after the AC is filled generously with OVD. With the IOL scaffold, phaco of the nucleus is initiated at the pupillary plane with OVD protecting the corneal endothelium. The whole nucleus is then phaco piecemeal to reduce risk of nuclear segments dropping into the vitreous. Next, 180-degree marking is done in preparation for Yamane IOL fixation. This is followed by anterior vitrectomy. Capsular remnants are then removed with forceps. More anterior vitrectomy is done with triamcinolone to highlight the vitreous. AC maintainer is inserted and needle guide markings done 2 mm from the limbus, followed by scleral tunneling of about 2 mm with 27 gauge needle. The leading haptic is grasped with VR forceps and docked and then externalized. Cauterization of the leading haptic is done till a terminal bulb is formed. Needle guide marking 2 mm from the limbus is repeated on the opposite side, followed by scleral tunneling of about 2 mm with bent 27 gauge needle. The trailing haptic is grasped with VR forceps, followed by docking and externalization of the more challenging trailing haptic. followed by cauterization of the trailing haptic till a terminal bulb is formed. More anterior vitrectomy is done. Peripheral iridectomies are done to prevent pupillary block issues. Wounds are checked for leakages and then haptic bulbs are pushed into the sclera. Post-op VA is 20/50. Take-home points are pre-op preparations, backup plans, and ensure all necessary instruments and accessories are available. Thank you very much for watching.